Now I know within
48 hours.
48 hours.
24,
48.
48.
Yeah, we've had complications up to 48 hours, delayed reaction. In relation to your question, I think there's two questions there. The first is, what type of hyaluronic filler should you be using so that you get less hydrophilic expansion of the filler? And then the second is, if you do use a filler that has got hydrophilic properties, is there a chance that you will get a delayed complication? Am I correct?
Yeah, but most deep line fillers are hydrophilic.
Well, yes, it depends on the type of filler that you use. So Sundara, who's not here, wrote an amazing paper in 2010, and she looked at all the most commonly used fillers, and she graded them group 1, group 2, and group 3. Group 1, if I try and stay away from brands, if I can, group 1 being calcium hydroxyapatite. These are Hydri Prime, high elastic modulus. So these are strong fillers that don't move without lidocaine. And then you've got group 2. These are calcium hydroxyapatite with lidocaine. And then we've got medium particulate fillers. These have a small amount of hydrophilic element to them, so it's usually 1-to-1. So if you inject it into a plane, you have quite good certainty that it will be, the end result will be pretty much what you expect. Then we have group 3. These are our small particulate fillers. I think it might be helpful to say brands, but I'll stick with that.
I think it's a good thing to say the brand.
Yeah, maybe we can have this discussion.
Okay.
Yeah.
So the third group is the low particulate fillers. These have the highest amount of hydrophilic element to them. So you overtreat because you know that they will come down. After the hydrophilic element comes, they will shrink. So they swell, but then they shrink. So in terms of safety, should we be using groups 1, the calcium hydroxyapatite, groups 2, calcium hydroxyapatite, or medium particulate fillers, or groups 3? These are soft fillers, safe fillers. They have some element of swelling, but they come down. The evidence suggests that we should be using, in terms of safety, we should be using groups 2 and groups 3. Group 3 being the safest because they're reversible. We do have some swelling, but that swelling is not associated with an increased risk of necrosis. So in answer to your question, the hydrophilic swelling is not associated with increased necrosis. What it is associated with is more erythema, and some pain, but not necrosis. Looking at why necrosis happens, in the nose, there's been no evidence that it happens due to compression. Mostly it's through direct injection into a vessel, that's what the current evidence is saying, that it's unlikely to be solely due to compression.
I understand. Just one other small point is in relation to volume injected. There is some correlation with a level of 0.5 mils, and I think particularly when people are starting out, if they try and stay below 0.5, there is a suggestion that there's lower risk.
So that's great. I think we have to stop here, and I must highlight the point that Cormac has made at the end. Very important, not only the total volume in the nose, but also every time you inject the liquids you are injecting, try to make them as low as possible, because this is a hyaluronic acid. If you are injecting, it is going to be integrated within the tissue if you are injecting, around the tip, or it's going to be working as an implant if you are injecting in the supraperiosteal space. In both areas, you must inject very, very slowly and a small liquid at the time. Never ever inject quickly or a large bolus when you are working around this area. I would like to thank all the speakers in this first master class, and thank you all for your attention. Can we please